Welcome. It's so wonderful to see so many people here this evening. And when I was reviewing the registration list, I did also see some of you had registered for the previous events that we had to cancel or reschedule due to inclement weather. So third time's a charm. We're finally going live, so really appreciate your flexibility. My name is O'Brien Gossage, and I'm the Associate Vice President for Riverside's Neuroscience Service Line. And on behalf of the team and our providers, we're truly grateful to have you with us here this evening. Today marks a significant step in raising awareness, sharing knowledge, and fostering a supportive environment for those affected by tremors. We know living with this condition can pose unique challenges, not just physically, but also emotionally and socially. And together, we can form a network of support, and we can leverage events like this to truly raise awareness and promote an understanding of the diagnoses, as well as some of the latest treatment options available. At this evening's event, you're going to hear from two of Riverside's distinguished physicians, and they're renowned for their expertise in movement disorder as well as functional neurosurgery. After each of the presentation, we'll then open it up for a 15-minute Q&A to allow the audience to engage in tonight's event. So without further ado, it is my pleasure to introduce our first speaker this evening, Dr. Suran Rajan with Riverside Neurology Specialist. Dr. Rajan is a board-certified, fellowship-trained neurologist specializing in movement disorders such as Parkinson's disease, essential tremors, dystonias, tics, Huntington's disease, and Tourette syndrome. After completing medical school in India, Dr. Rajan earned his Master's of Science in Clinical Neurology and subsequent research fellowship from the UCL Queen Square Institute of Neurology in London. Following an internship with the University of Missouri, he completed his neurology residency at Wright State University before pursuing subspecialty fellowship training in movement disorders at Johns Hopkins University. He currently also serves as an adjunct assistant professor in neurology with Johns Hopkins University. He is certified by the American Board of Psychiatry and Neurology. Please help me in welcoming Dr. Rajan.
Hi everyone. I think I've seen a lot of your faces actually before, so don't shout at anything that we have spoken in the clinic. So let's take that out of the clinic and we'll talk about generic stuff. If you have any questions about anything very specific to your own condition, remember this is being videotaped and your voice probably might be on the video, so just make sure that you keep your private health condition as private as you can, okay? So my part of the talk is the medical side of tremors, and then obviously Dr. Lamm, our neurosurgeon, is going to talk about what we can do from a surgical standpoint and what are the procedures we can do to actually treat tremors. Tremors in general is a word used to describe shakes. All shakes are not tremors. Obviously, a seizure is not a tremor. Things that we are talking about today are rhythmic tremors that if you look at the hand or look at the part that is shaking, you'll see somewhat of an oscillation around an axis. For example, this is kind of an oscillation. I'm slowing down my shake and showing you what it looks like when you really slow down a shake or a tremor. It is kind of rhythmic. You can kind of see how many times it's going up and down in a second, which is what we call the frequency of a tremor. And then we're looking at which axis. This is my hand, so you're looking at how the tremors going around the wrist. Sometimes it's like a no-no around the head and neck. Sometimes it can be like a yes-yes tremor. So an axis and the frequency and which part of the body is shaking. These are the three things that we look for as a tremor specialist to see and put a name to that tremor. Enhanced physiological tremor is probably the most common tremor that we have seen. This is basically the literal shaking of your legs when you have some sort of anxiety or you're afraid of something or stressed out or excited, right? Like you can feel a little bit of a shaking inside your belly called the butterflies when you're about to be, seeing somebody who you are excited about, or, you can have that when you're actually falling down, down some sort of, height or something like that, right? The other enhanced physiological tremor that you might probably see is when you have just had a good workout, right? Or when you're kind of, sitting down, kind of lunging forward or something, your legs can kind of shake, and that's also enhanced physiological tremor. So essential tremor, the word essential comes from the word essence. It is part of your body. Way back when essential tremors were being described in the French neurology world back in the 1700s and 1800s, they thought that this kind of a shake was part of your constitution. This was not the only thing that got the name essential. You've heard of essential hypertension, right? Or essential myoclonus. There are a bunch of essentials. In fact, high cholesterol was also at one point called essential hyperlipidemia. We thought that this was actually constitutionally your body was designed to have a shake, or constitutionally your body was designed to have cholesterol or high blood pressure. That was what the thought process was back in the day. Currently, the thought is this might be actually a bunch of tremors that we kind of pull together and then call them essential tremors. So the other one, previously called senile tremor, we used to think that this was actually happening. This happened to people who were older than 80 or 70. We call it now, the word senile has a lot of negative connotations, and we call it age-related tremor, or ART. We think age-related tremor is actually the little sister of essential tremor. We don't think that it's at a separate entity. It's most likely essential tremor. Dystonic tremor is when your body, a part of the body is told to tighten up by your brain, and then the brain tells the other part of that, say, other muscles of the same part of the body to relax. For example, your head kind of goes this way, and then the other side gets pulled, and then the head corrects this way, right? And eventually, when you look at the patient, you have a tremor like that, like a no-no tremor. This is somewhat of a dystonic tremor because the brain is telling one group of muscles to pull one way and the other group of muscles to pull the other way. So this causes a tightness to the muscles, and eventually that kind of tightness causes this tremor to become more and more in one direction or one way, to the point where the body, that part actually can be twisted to an extent. For example, you'll see something called torticollis, where the head can be in one way or the other, this way, or sometimes even it kind of looks like it's bent or held backwards. But in that process, the muscles are also sort of relaxing and contracting at the same time. The opposite muscles are contracting and relaxing. So one group of muscle will be pulling it this way, contracting. The other group of muscles is kind of pulling it backwards. So that push and pull sort of causes this very high frequency sort of a shake. That's what dystonic tremor means. It can happen in the hands as well. We'll see them sometimes happen in the legs, but very often dystonic tremor is seen in the head and neck area. I see a lot of my patients here, so most people know that Parkinson tremor is very much sort of a pill rolling tremor that you start having in the hand very often. Now again, Parkinson tremor does not necessarily need to be in one hand or the other. It can be in the head and neck, it can be in the leg, but most common, 95% of the time, Parkinson tremor starts in the hands. It usually starts on one side, and then maybe a few years later, you'll start seeing it on the other side. Now, a lot of patients with Parkinson tremors think they have another tremor, or vice versa. And most of the time when patients come to our medical clinic, their question is, do I have Parkinson's? Because they have read up on tremors, and then the first thing that comes online or in a library book or anywhere, it's usually Parkinson's disease. So that is the usual question. So they're generally very relieved when I tell them that this is not Parkinson's, this is essential tremor or something else. Orthostatic tremor, I think we have a few patients here who have this. Orthostatic, it's Greek, two Greek words kind of mashed together. Ortho means perpendicular, and static means standing. So when you're standing on the ground perpendicular to the floor, this tremor happens. That's all it means. But actually, orthostatic tremor is a very particular type of tremor that happens in the calf muscles or the leg muscles. You can have it not just in the calf muscles, it can actually be in the thigh muscles, in the hip muscles, in the back as well. But most of these patients will not be able to stand still. They'll have to walk around or sort of hold on to something because their legs start shaking when they stand up. It starts kind of like a little bit of an itchy feeling in the leg, as if the muscles want to just move or muscles want to just kind of twitch. After months of this happening, over time, the legs start kind of shaking a little bit. And when you stay where your calf muscles are contracted, you start having a lot of shakes, so they have to actually kind of move around to distract themselves or have a better balance. That's very common with orthostatic tremors. Thankfully, it is very rare. It is probably, of all of these tremors, it's probably the hardest to treat, maybe after cerebellar tremor. No medicines other than one particular medicine that is a cousin of Valium, called clonazepam seems to work. And that is actually a medicine that causes a lot of sleepiness, so people don't like that medicine. But again, it really seems to work in a small group of patients. Neuropathic tremor. Neuropathy, I think everyone knows neuropathy. It's basically something that happens to the nerves of the hands and legs after you have had either diabetes or small vessel disease. In some cases, you can have trauma and have neuropathy as well, but very often it's diabetes and small vessel disease. But you can also have this after a bout of chemo. Medications are very well known to cause neuropathy. Sometimes blood vessel flow or blood flow to small blood vessels of the body can actually cause loss of nerves, and that can cause neuropathy. We don't know exactly why neuropathy causes tremors. Not every patient, only about 1% of neuropathy patients actually end up having tremor. And those patients also have tremors only quite late in their life and then in only advanced cases. So we think that the tremor centers in the spinal cord are affected in these patients, and that is what causes to bring the tremor out. Neuropathy tremors are also hard to treat because the usual medications that we use for essential tremor Parkinson's disease, they don't seem to work that much. And the neuropathy is also not treatable. And neuropathy, without the tremor, neuropathy just presents as tingling and numbness and sometimes even weakness of the limbs that are affected. So that is actually the hardest thing to treat. The nerves don't grow back. But the shaking, when it comes with it, we try medicines that are used for other tremors, and sometimes they help, but they're also one of those hard tremors to treat. Cerebellar tremors. We're going to talk about the cerebellum in a second. Cerebellum is a tiny organ in the back of the brain. This tremor actually is caused by this part of the brain being affected, either visibly because of a stroke or a bleed. Often bleed in the brain, in the cerebellum, causes a big tremor. Strokes don't cause a lot of tremors there. Sometimes you can have symptoms of tremor from cerebellum if you have had an infection in the cerebellum. We have had patients who have been admitted here with a brain infection and end up having tremors of the body because of the cerebellum. It's a very rare tremor. Often we see cerebellar tremor as a component of your essential tremor. I think some of the patients here who have been treated for tremors I've told them, yes, you have essential tremor and a bit of cerebellar tremor. We call it sometimes essential tremor plus syndrome. That plus stands for something else in addition to essential tremors. Psychogenic tremor, it basically means that either you have a psychiatric reason for having a tremor, or you have a secondary concern, like an anxiety or a stress that is bringing out a tremor. Psychogenic tremor is probably the easiest to treat. You basically tell the patient that this is coming from anxiety or stress. We treat the anxiety and stress, and the tremor usually goes away. One of the good things about psychogenic tremor is it's usually non-disabling. Your brain knows that this tremor is being caused into your body because of your psychiatric stressors in the background. So once the brain knows to cope with it or learns to live with it, the tremor also kind of ebbs and flows. There are situations where the psychogenic tremor gets worse, and then patients come to me, and then we treat the psychiatric problem, and then that usually takes care of the tremor part as well. Just a little bit of anatomy. I'm not going to bore you with all the Greek and Latin. You see a head sliced open actually. It's a real cadaver, and you can see the cadaveric brain in there. The arrow is pointing to a part of the brain called the thalamus. It's a Greek for bedroom. I mean, it's not really a bedroom, or it was called bedroom because the people who discovered these, or not discovered, started explaining these things in the 800 AD, or maybe before that actually. It was explained, I think, in 180 by Galen. Galen called it thalamus because he thought that this was actually a chamber where the eye nerves actually converged. Thalamus is one part of the brain that we have really worked a lot on to figure out where tremor is coming from. Thalamus is a center of consciousness in general, like it basically wakes you up in the morning. It is also where all the sensation from the leg, or from the tip of the toes all the way to your face and the eyes actually converge, and then gives the brain the relay to these things. So it's basically like a radio station or a relaying tower for the brain. It also controls fine motor tasks, but that is one of the areas where fine movements are controlled. So if you hold your hand up like that and then pick up something that is as delicate as this, your thalamus knows, and thalamus, it's not just thalamus, but thalamus is one of those areas that really play the big role in there. It actually sends signals to the rest of the brain and also tells the rest of the brain how to hold an object. You don't have to actually have seen this. Any baby who has seen this for at least 2 years or so knows how to grab it. The baby doesn't grab it like that. It knows that it's a cylindrical object, so curl your fingers and hold it like that. If this is actually something tubular, it knows how to actually pincer grasp. All of those little fine movements are kind of programmed in the thalamus. Thalamus is not just that. It also has other functions, but I'm just saying that just for the sake of this talk. Next part of the tremor circuitry is the mesencephalon, or the middle brain. This one helps the thalamus kind of fine-tune the signals that come from there. And then there's another part called the cerebellum. Cerebellum is basically Latin for little brain. This part of the brain is tucked away in the back of the brain. We talked about cerebellar tremor just a while ago. So taken together, these three areas are the parts of the brain that really kind of collaborate to help you with fine movements of the body. And any problem in this area, obviously you can have a tremor. A fourth part of the brain called the corpus striatum up there, and then one more area, the next part called the amygdala, also plays a big role in it. That amygdala, that's Greek for almond, this almond-shaped thing, that green little thing there, that's the center of emotions. So you can imagine, right? If you're really worried, you can shake, right? You can, if you're anxious or, angry, you can actually shake with anticipation or shake with anger too, right? The corpus striatum actually is a part of the brain that smoothens out a lot of our movements and make it automatic. And anger centers are also involved in this. Because we call it anger center because amygdala, anger or anxiety center, where when they were discovered in mice that actually were fretting and running around. So we decided that this will be the anxiety center. But it's not just the anxiety center. We are helped by this organ in a million ways. It actually tells us, what to worry about and what not to worry about. If it is well lit and the alleyway is good and, you see a friend smiling in that alleyway, this is not a dangerous place, so you don't have to worry about it, right? So it has a lot of protective, features in there. Whereas if it's a dimly lit alleyway and you see strangers in there and they look a little sketchy and, one of them has a gun, obviously you have to be worried about it, right? They're named after these things because, when people were actually discovering these things, we call them that way because we test it out in a mice or another lab animal, and you see this, pattern happening in that. But that is not the only function. That's basically what I'm trying to say there. These two areas, corpus striatum and amygdala, actually help us, in two things. Give an emotional aspect to movements. The other one is to actually automatize it. So for example, when I'm walking, my arm swing is pretty automatic. And when I talk, these movements, I talk with my hands all the time. So those movements are automatic. My legs kind of spreading out my center of gravity and trying to actually lean on this or do all these acrobatics. All of these are automatic. And these automatic movements are actually helped by corpus striatum or the basal ganglia that's around that. And that means that the brain doesn't have to spend a lot of energy consciously thinking about it. You don't consciously think about swinging your arms, but why do you swing your arms? All apes swing their arms because this is how we preserve our center of gravity. If you walk like that, you're actually going to fall pretty quickly. It's also one of the things that most of my Parkinson's patients know. I make them walk in the hallway and tell them, oh yeah, your arm swing is pretty good. Or I'll tell them, your left arm is not swinging. We need to actually get you to physical therapy. A lot of our people have heard this. Get you to physical therapy, let them work on your arm swing, right? Because that is actually how apes, ourselves included, all monkeys and apes actually use these big, long, dangly things to actually control our center of gravity. Just to give you a summary, we have 3 organs that smoothen out your movements. You have one of them that actually makes it automatic, and a fifth organ that actually gives a little bit of an emotional quality or emotional quality to your movements, right? All of these are actually involved in tremors, but the first part, the 3 ones, are the ones that usually seem to have all the circuitry of tremors in there. You have a stroke in the cerebellum or a bleed in the cerebellum, the circuitry is abnormal. You have a midbrain problem, the circuitry can be abnormal. You have a thalamic problem, the circuitry can be abnormal. Of the 3, thalamus seems to be actually able to take a lot of hits and not end up causing you a lot of problems. Which is also why Dr. Lamm and his colleagues actually like thalamus quite a bit. And that's where a lot of the procedures that are done in the neurosurgery world to treat tremors actually are. And this is mostly because thalamus has a lot of tiny, tiny centers. Although it's a small, you can see that, it's not really that big. But even within that, there are centers that we can isolate and then spare the other centers when we are treating it. All the other ones, they all sit in very dangerous areas. So we can't fiddle with them that much without causing serious problems. Cerebellum, for example, the circuit is a mess. There is no tiny area in there where we can play around and not harm the other stuff. Midbrain, your consciousness actually is gone if you really have a big bleed in there. If you have a tumor in there, you're gonna not wake up. You will have paralysis below the neck because the center is so small and everything is too tight in there, whereas thalamus, we have a little bit more space to actually spread out. But in maybe 20, 30 years or so, we might actually invent better equipment to play around with these tiny organs in the lower part of the brain, and then maybe we'll have more procedures that Dr. Lamm and his colleagues can work on. We'll talk about the treatment for essential tremors, propranolol and primidone. Again, I know that the audience is not medically trained, so when I throw out these chemical names, just ignore them. But just for the sake of it, propranolol is a cardiac medication. It was invented in 1963, came into the market and became popular around 1967. Metoprolol or toprolol is the granddaughter of propranolol. Propranolol is this grandmother that was the kick-ass, jack-of-all-trades medication back then in the 60s. Because it was invented to slow down the heart rate and was invented to lower your blood pressure. Propranolol has this problem though. It entered the brain quite a bit, caused you to have nightmares if you took it in the evenings. It also caused you to lose your sleep if you took it in the evenings. Plus, it also entered the lungs, made your asthma worse, and back in the 60s when we had a lot more smokers, it made their wheezing worse as well. So people started looking into other medications and then ended up discovering nebivolol, bisoprolol, and metoprolol. So they said, propranolol can wait in the, somewhere else. We can just use the granddaughters because they are better for cardiac purposes. So nebivolol, all the other olols, they're all alcohols. That's why they have the olol at the end of the name. They became sort of like the go-to medication for cardiologists, that we didn't need propranolol. But obviously, neurologists loved propranolol because it enters the brain. Not a lot of medicines enter the brain. It's very hard to get medicines to get into the brain. If they get into the brain, they make you sleepy, so they're useless most of the time. But we have this medicine that actually enters the brain, goes straight into the thalamus. So that's where we want it to work, right? Propranolol also goes into the amygdala. Remember the anxiety center that I showed you, the little green dot there? So it can calm your nerves down. Propranolol is a great medication that you can take if you have stage fright. For a good speaker, this is great, right? I am not on propranolol, by the way. But, this is all okay. This is all natural. Propranolol actually can lower your heart rate, and the heart nerves tell the brain that everything is calm. Your heart is actually working okay. So your brain feels like, yeah, I'm among company here. I'm among friends here, right? That's how the brain, the propranolol actually works to calm your nerves down. So anxiety center is calmed, thalamus is calmed, tremor gets better. This is how propranolol really works. As I mentioned, it's a heart medication. It can actually cause blood pressure drop. It can cause lowering of heart rate. There's a bunch of other things that happen. If any of you are, a person with atrial fibrillation or some sort of rhythm problem of the heart, probably not the best. But as you probably might know, I have always, told you that yes, propranolol can cause this, but we could try it in a small dose and probably bump it up, right? So that is how we try. We just tell patients, yes, these are the side effects it comes with, but let's take that risk and see if it actually works for you. Primidone is an old seizure medicine. We don't use it in humans anymore because we have 27 other better seizure medicines. Just like all the granddaughters of propranolol, we have great-grandsons and great-granddaughters of primidone. We have everything from levetiracetam to the latest medications like Vimpat and zonisamide, so we don't need primidone. Primidone is still used in veterinary science, so we use it in cats and dogs for seizures. It is actually a medicine that causes sleepiness. It becomes a chemical called barbiturate, which is the truth serum, right? So this actually can also enter the brain and work in your thalamus and also work in other areas of the body that actually causes tremor. So it also causes a tremor benefit by working in the thalamus. But it can induce sleep. So it can make you sleepy. So I usually start it at bedtime and then see if the patient can tolerate the sleepiness. Once they feel like their body is okay to work with this, I'll start introducing a tiny dose in the morning and then gradually increase it. So over time, once you develop some tolerance to this medication, it is actually pretty safe. Primidone has this one nasty habit. It actually makes other medicines less effective. Not all of them, but some of them. Especially if you're on a blood thinner or a psychiatric medicine, I might actually tell them, hey, this medicine might become less effective if you take primidone. In a young person who is on contraceptive pills or some other hormone pills, primidone can kind of, mess with them too. So we have to be a little careful about it. On the left-hand side, you see a bunch of add-on medications. Benzodiazepines, these are actually your Valium, Xanax, Ativan, all that stuff. There's one medicine in that group called clonazepam or Klonopin. Not a lot of people have heard of it, maybe, but Valium is like the most popular, gal in that group. But we try to use more of clonazepam. It's a good medication you can take at bedtime. It works in the amygdala, the anxiety centers, and really works in tremors that way. At high doses, it actually penetrates the thalamus and causes some of the thalamic circuits to be calmed out as well. Zonisamide is a seizure medication, topiramate is a seizure medicine, gabapentin is a seizure medicine. These are all tested and tried. Zonisamide is my go-to after I have failed propranolol, primidone, and benzodiazepine. They all have their own side effects. Your kidneys need to really work well for zonisamide to pass through. I have to check kidneys and make sure everything is okay there. Topiramate, I have to make sure that your memory is good because topiramate can actually slow you down in your thinking. Gabapentin and Lyrica, which is pregabalin, these are two medicines that people use for neuropathy quite a bit. As you go down the list, the effect on tremor is actually less and less. So I usually try to throw in the first two and then maybe a third one. I don't usually go for the fourth or the fifth unless they cannot take anything else. And then I'll go through the list and then see what can work for them. Levodopa, it's great out there because it's a question mark medicine. Levodopa, a lot of people with Parkinson's disease know that that's my go-to. Everyone's go-to medication is levodopa. It basically becomes dopamine in your brain. So in Parkinson's disease tremors, dopamine actually is needed and you treat it with dopamine. In some patients with essential tremor, we have found levodopa to be helpful because some of the circuits that are affected in Parkinson's disease patients are also affected in essential tremor patients. We have touched upon a lot of these things. I'll just mention that propranolol has a short-acting and a long-acting version. So I try the short-acting version until my patients tell me that, yes, we have reached a good dose, which I can now convert into a long-acting version. The long-acting version is useful if you don't like too many pills. The long-acting version will be like a once-a-day pill you take in the morning and forget it. The problem with long-acting version is because you upfront load yourself with a bigger dose, the side effects are also pretty heavy. So you can have a lot of blood pressure drop, you can have a little bit of dizziness with it. So I usually warn my patients, hey, this is the problem with long-acting. So maybe you want to go to the short-acting version and take it in a smaller dose, maybe multiple times a day. What is next in medical management of tremors? We have 3 medicines that are in the oven. They're not ready for prime time, so we're still going to wait for this to come to the market. The first 2 are called suvecaltamide, made by Jazz Pharmaceutical, and the second is ulixacaltamide. It's from Praxis. There is a calcium channel that was sort of played around with in the 90s that we have reinvented again, and we're testing these drugs again. There are 2 big groups of trials that have been completed. They went online in 2019, and in 2020, you know what happened. So after COVID hit, we had to actually kind of wind it down, and then everything went online. The data collection was a mess, so we didn't really get the results that we wanted. So these are 2 sets of medicines that we think might come to the market maybe next year. One of them might actually, get accelerated approval later this year, but most likely it's going to be 2026, sometime around October. We might probably hear from it based on how, FDA approves it. This slide is actually old. I thought it was actually coming out in 2025, but nope. The good thing about these two drugs is they don't seem to have the side effects of the propranolol. They don't seem to be working on your heart. It doesn't actually cause a lot of lowering of your heart rate or anything like that. None of the side effects of primidone either, so they don't cause a lot of sleepiness either. So that's a good thing. We don't know a lot of bad things about it because the trials are still going on. So we'll keep you guys posted. The third medication in that is actually a medicine that is very similar to your gabapentin. They actually seem to be producing this calming effect that gabapentin or your benzodiazepines produce without all the side effects of it. So that's all we know about it. This is still in the phase 2, which means phase 2 trial is when you test it out, not for the effect of the drug, but for the safety and the dose. I think Dr. Lamm is actually up for the next talk. Before that, I think, do we have Q&A? Perfect. Questions? So it's a yes and no answer. The no is because a lot of the regular eye twitching has no connection to tremors. But a lot of patients with tremors can have rhythmic twitching of the eyes with the tremor. But if the eyes are twitching by themselves, that's not tremor. There are two conditions where eyes can twitch abnormally. Again, a lot of eye twitching is normal. I don't want to make it a catastrophic thing here, but this kind of blinking, and then after a bunch of blinking, the eyes kind of getting shut down is called blepharospasm. So there is a name for that. The other one, the most common eye twitching that everyone sees at the end of the day after a very long day is a twitching under the eyelids. That's called myokymia. If you've had too much of coffee, or if you have had no sleep for at least 24 hours, or you had a long day in surgery, you could have an eye twitch, right? Yeah. With the tremor, yes. Oh yeah. So tremor and your, like I said, right? The thalamus really helps you kind of grip on things, and if you have a lot of tremors, you can drop a lot of things. Yes, that's normal. When patients tell me that they drop a lot of things, and I look at my notes and say, oh yeah, this patient has never actually dropped things even though she had a really bad tremor, then I might actually look at other reasons for dropping things too, because you can have, loss of strength, not because of tremors, but because of a completely different thing. You can have neuropathy, you can have cervical neck problems, you can have carpal tunnel syndrome or muscle changes in your body that could actually make you weak and drop things too. So those things need to be evaluated, but generally if you're shaking and if you're dropping things, it could be related to the tremor itself. Clonazepam. So Klonopin or clonazepam, that is the medicine that is used for orthostatic tremor. I have tried zonisamide as well, and it seems to work. I didn't invent it. Obviously, I learned it from other professors and teachers that I've trained with. A lot of people have just thrown a lot of medicines at orthostatic tremors because I mentioned that orthostatic tremor is very hard to treat, and we don't find the very satisfying, happy medication in orthostatic tremor. We get to a point where we can say, okay, yeah, the patient is getting by without a lot of falls or something like that. That's as far as we go. And then people tried zonisamide and then said, some of the patients have come back and said, this is magical. So zonisamide or zonagran is actually a seizure medicine that you can try. Clonazepam is the first line to try because that has been tested for about 30 years or so, and there is somewhat good data to suggest that that could be the thing. The problem with clonazepam is the small doses that people use are not enough, and that you can imagine, right? Even 0.5 milligram will put you to sleep. In orthostatic tremors, you need to try almost 5 milligrams, not 0.5, 5 milligrams or more. So you'll have to inch it up very gradually to get you used to it. And because it's a controlled substance, it's a nightmare to prescribe. So you have to have a neurologist who is absolutely going to be, behind you, giving you all these stuff, right? Anything else? All right, so that's it. Thank you.
Thank you, Dr. Rajan. All right, it's my pleasure now to introduce our next speaker, Dr. John Richard Lamm with Riverside's Hampton Roads Neurosurgical and Spine Specialist. Dr. Lamm is a fellowship-trained neurosurgeon who specializes in brain and spine surgery, including functional neurosurgery. Dr. Lamm possesses expertise in the surgical treatment of brain, spine, and peripheral nerve disease. In addition to general neurosurgery, he has specialized training in brain and spine trauma, peripheral nerve surgery, gamma knife radiosurgery, deep brain stimulation, and focused ultrasound. Dr. Lamm earned his medical degree in 2013 from the Brody School of Medicine at East Carolina University. He completed a neurosurgery residency and a fellowship in functional neurosurgery at the University of Kentucky in 2018. Please help me welcome Dr. Lamm.
I know Dr. Rajan already talked a lot about how these tremors work and how they affect people and things that we try to do to treat people to get them better. And a lot of times we get on the case after people's disease becomes so severe that it's refractory to medical therapy. So I have a couple slides here, a little bit about Parkinson's disease and essential tremor, although we can kind of fly through these pretty quickly since Dr. Rajan talked a lot about it. But Parkinson's disease is usually onset a little bit later in life. It is a more widespread disease than just the tremor. A lot of people have rigidity and slow movement or bradykinesia, loss of balance. It's a progressive disease despite medical treatments or even our surgical treatments. So the best we can usually do, with the exception of some experimental things that are out there, is to slow the progression or at least quell a lot of the symptoms that people have to improve their quality of life. Later in the disease, dementia is very common, and as it affects all aspects of people's life, depression is also a common thing to go along with it. A couple statistics there, it's pretty common in the way of things that we deal with. It's caused by a loss of dopamine secreting cells in the deep brain or basal ganglia. In some instances, it's hereditary, but exactly why people get it, there's a few types that we're kind of nailing down, but for the most part, we don't really know. Some people get it and some people don't. With essential tremor, it's a rhythmic shaking. It's hereditary for a lot of folks. It runs in families, so we'll end up doing surgery for some folks, and then we meet their brother or sister, or sometimes even their children. It can affect the arms, is where most people seek out treatment, as it affects a lot of things they do during the day, but it also affects people's head. And a lot of people have a voice tremor that goes along with essential tremor. So it's also very, very common, so we see a lot of folks with this. The deep brain structures, Dr. Rajan talked about some of these specifics. There's a few targets in here that we use for our treatments. The most popular, like he already mentioned, is the thalamus. There's a lot of small areas there that are compartmentalized. So it's a great area for us to target with deep brain stimulation, which I'll talk about here in just a minute, as well as our lesioning procedures. There's a few other targets that we use for other issues that aren't tremor, like obsessive compulsive disorder is a place that we can treat with some of these procedures that I'll talk about, as well as dystonia and a few other psychiatric conditions. As far as Parkinson's treatment go, Dr. Rajan already talked about the medications and non-surgical things. As far as my expertise comes in, deep brain stimulation is our tried and true gold standard treatment. It has been widely commercially available and accepted as a good treatment, a solid treatment, the best treatment since probably about the 1970s. Now, of course, our techniques have been honed quite a bit over the past 50, 60 years. It is still one of our most commonly used tools to treat the types of tremor. Lesioning procedures, they came in vogue more so in the 80s, I would say. So Michael J. Fox, for example, is a famous patient, Parkinson's disease. This is how he was treated. And so a lesioning procedure is where we basically create a hole in the brain to disconnect the circuit that controls the tremor or some of the other symptoms that go along with Parkinson's disease. Our newer treatment that I'll also talk about is the MRI focused ultrasound treatment, which technically is a lesioning procedure as well. And it uses ultrasonic energy, doesn't require any incisions in the head or things to be inserted in the head in order to complete the procedure. For essential tremor, medications are available, which Dr. Rajan already talked about. The surgical options for this are very similar to Parkinson's disease. We use different targets with our deep brain stimulation and lesioning procedures, and then there's also our focused ultrasound treatment. With deep brain stimulation, this, I kind of explain this to a lot of people as something more common people see, like a pacemaker. So this is kind of like a pacemaker for the brain. So a wire or an electrode gets implanted into specific regions of the brain. There's different targets for different diseases, like the essential tremor and Parkinson's disease specific to today. The implanted battery goes just above the collarbone, or just below the collarbone, like people see in a pacemaker, except instead of the wires going deep down to the heart, They come underneath the skin, up behind the ear, and up to the top of the head. And then from the outside of the head, we insert them into the head, which is the technical part of the procedure. The battery can be adjusted. So as people need to figure out how they want their tremor treated or exactly how awful their tremor is, we can turn the settings as high or as low as we need. There's multiple contacts along the wire, so we can adjust the treatment to fix people's hand tremor, maybe their voice tremor, head tremor, even a leg tremor. And then in Parkinson's disease specifically, as it's progressive, we can turn the treatment up as people's disease progresses, which is why it's become such a great treatment for that. And then now we have sensing electrodes, which is kind of the latest technology as far as deep brain stimulation goes, in where the electrodes or wires and battery can not only deliver treatment, they can also measure people's neuron firing. And so the treatment is now being adjusted automatically as people develop symptoms, and their tremor goes up and down throughout the day. With deep brain stimulation, it can be applied to both sides of the brain during the single treatment for either Parkinson's disease or essential tremor. It is a brain surgery, so it requires people to come to the hospital, it requires general anesthesia for a portion of the procedure, and people are hospitalized. So it's a real surgery. It's a great surgery in the way things that we do to people's brains. I would say it's minimally invasive, but brain surgery is a big deal, so we reserve it for people that really have trouble and have tried everything else first. This is kind of a diagram here from the Cleveland Clinic that illustrates kind of how this works. So there's a wire that goes in on either side of the brain. Usually it's behind the hairline. And then the deep portion of the brain is where the contacts are. The wire comes out of the head, is connected to an extension, goes back behind the ear, and then ends up connecting to the battery just below the collarbone.
It looks like a scene from a sci-fi movie, the medical science of the future. But it's happening right now in one of the new, high-technology-based operating rooms at Riverside Regional Medical Center.
My name's Tom Larson. I'm 58 years old. I noticed my tremor about 7 years ago. I've gone through all the medicines. It did nothing for the shake. So now I'm at the point of brain surgery. Heard a lot of good things about it, and hopefully it's going to be the answer to my dreams here. Put me back in touch with the real world.
Tom has a tremor, an uncontrollable shake in his hand caused by a neurological disorder. He's researched the options, he's studied the procedures, and he's ready for one of the most advanced surgeries modern medical science offers, deep brain stimulation surgery, or DBS.
The technique that we used for the surgery is referred to as stereotaxis, mathematical calculations and geometry to reach targets inside of the brain. We used a combination of the MRI scan and CT scan, as well as a sophisticated computer program and graphics station.
Dr. Jackson Salvant, a neurosurgeon with Riverside Medical Group, and his team of experts make the final preparations on an array of 3D computer imaging equipment and high-tech X-ray-like sensors used in this procedure. These computer sensors will guide Dr. Salvant to the area in the brain responsible for the unwanted tremor symptoms. A millimeter can be the difference between success and failure.
My hopes are tremendous. Get back my life, learn to write again, learn to be out with people, learn to relax. I can't relax. Everything is so stiff, so tight, because you're trying to prevent it from shaking so much. We did research on Riverside, and I feel I'm in great hands. I'm getting the top-notch guy in this field, and really looking forward to doing this.
In fact, Riverside Comprehensive Neurosciences has the only facility on the Virginia Peninsula that offers this unique and advanced treatment option.
It's very important that we select the patients carefully. It's always in the patient's best interest to begin consulting with their neurologist before they consider surgery.
When the electrodes are in the target area, a small electrical charge is generated to alleviate the symptoms without causing unwanted side effects. Once a stimulating lead is precisely placed, it is later connected to an implanted pulse generator, similar to a pacemaker. The device then transmits painless electrical pulses to interrupt signals from the brain that cause the tremors. The entire surgery takes about 2.5 hours, and the results are immediate. Tom was back at home the next day.
Before surgery, he couldn't perform his signature. After the operation, we could see a very nice fluid signature. We saw a definite improvement in his tremor. All of the indications during the surgical procedure were that it was going to be a success in the long term.
Thanks to this cutting-edge technology, Tom's life is back to normal.
Big difference is no shakes. Been able to write, been able to communicate better, confidence levels up. I had a great experience with the hospital. Riverside was super. I just want to thank them for giving me a chance to get my life back.
So that's deep brain stimulation. So a lot going on there as well as all the equipment, operating room, but it's one of our favorite procedures to perform because it's such a stark improvement for folks and people get back to being functional, healthy, hardworking folks. The procedure's usually completed over a couple of sessions, and so the reason for that is during deep brain stimulation surgery, people have to be awake. We have to see people tremoring to make sure that we're doing a good job, that we are fixing their tremor, and then, like the video mentioned, a millimeter can make a difference. And so we're talking about fractions of a millimeter as far as accuracy and precision go. And so we want to make sure that we're not causing more trouble than is already there. And we get to make adjustments during surgery to make sure everything's perfect before we're done. And so we need the patient to be awake and interactive with us during the brain portion of the procedure to make sure that we've done a great job. But that's also why the procedure is so successful, is because we know we've done a good job and the patient's satisfied before they are even done. The second portion of the procedure is typically done with the patient asleep. Different surgeons do it different ways. I like to do that portion of the procedure first, and that way we can get done with all of the painful things. And so that would be putting a battery just below the collarbone, which requires an incision, and then also passing the wires underneath the skin up to the brain. Or up toward the head, so we can access the brain. And the other thing I'll do while people are asleep during that session is I'll go ahead and drill the holes in the head. So nobody really likes to be awake for that part, as you might imagine. The second portion of the procedure where the leads are actually inserted into the brain, I don't know, a lot of people don't know this, the brain actually doesn't have any sensation. And so people don't feel anything while we're doing that portion of the procedure. So other than it being a very weird day, and sitting under some bright lights and talking to a lot of people you don't know, it's not terribly uncomfortable. That part of the procedure, people typically spend one night in the hospital and they're back to normal the next day. The controller is actually, these days, those refurbished iPhones. So if you wonder what happens to your iPhone when you turn it back in, they repurpose it and link it up with these systems, and people walk around with an extra iPhone and they can make small adjustments. So that's the deep brain stimulation procedure. Certainly we can take more questions about that here at the end. The lesioning procedures, this has historically been done with heat or a cryoprobe, cold, deep down in the parts of the brain that control the tremor, the circuits that control the tremor. And with these, we disconnect the circuit that controls the tremor. So these two are very successful treatments. The downside to these treatments are they are permanent. Once this occurs, there is no adjustment to be done, like the deep brain stimulator. They historically required a surgical incision, also with the patient awake. We make a small hole on the head, and usually a wire or a probe gets inserted, and the heat or cooling mechanism is used to create the lesion. These were mostly abandoned as we honed the techniques and the success increased for deep brain stimulation. So those kind of fell out of vogue for a while. One of them did stick around, that was with the radiation, mainly for folks that just weren't healthy or maybe were too frail to consider going through a big brain surgery. It was a good kind of backup plan for folks that had to have something done and the medicines weren't working. There's pros and cons to that. We really try not to do that, except in very special cases where people can't get through this kind of thing, especially with our next procedure, the MRI-focused ultrasound. And so this kind of supplanted the radiation lesioning in that this does not require any incisions like the traditional lesioning procedures. This is a lot newer than our other treatments. New, it's almost 10 years old now commercially. And so it's non-invasive. It's an outpatient procedure, meaning people come in at breakfast time and they're home before lunch. It is used to treat essential tremor or Parkinson's disease-associated tremor. With this particular treatment, we only treat one side at a time. Both sides can be treated, however, it's spaced out by about 9 months. And so the reason for that's kind of arbitrary. When this received the testing, the FDA approved it to be 9 months apart because that was how they conducted the safety studies. When they invented the procedure, people had it done to one side and they determined it was safe, it worked really well, and people liked doing it, so it became commercially available and they started doing it all over the world, really. Everybody was very nervous about doing it on both sides. Sometimes when they invented these lesioning procedures back in the 50s, 60s, 70s, people became very sick after we tried treating both sides at one time for reasons that at the time we didn't understand. Now we know a lot more about the anatomy and the tracts that go through the brain. And so with some small adjustments to the positioning and the way that we treat people, it's very safe to do both sides. However, when they invented it and when they submitted all the research studies to the FDA, the average time seemed to be about 9 months by the time they got somebody back in to do the other side. So for right now, until more research studies are completed, where people get them done in the same setting, we're offering it at 9-month intervals. It works great. We've had plenty of patients come in and get one side treated and then come back and get the next side done 9 or 10 months later. So I think that's a testament to how much people like getting it done and how much it helps. The other downside to this is that it doesn't treat some of the Parkinsonian symptoms that aren't tremor. So it's extremely effective in treating people's tremor, but it is not really effective at all in treating the rigidity and balance difficulties and the bradykinesia or even the dementia that goes along with Parkinson's disease, the way that deep brain stimulator can be a lot more helpful. And so for our folks with Parkinson's disease, before we embark on a surgical endeavor, we have a big talk about what's going to be the best thing for that patient. Having a lesioning procedure like the MRI-focused ultrasound does not preclude people from having a deep brain stimulator. So in a few cases, we've done both. And so where somebody's been very pleased with the way their tremor's been treated, but as some of the other symptoms catch up with them as time passes, they'll come back and see us, and sometimes we'll do that deep brain stimulator procedure. This is the MRI-focused ultrasound machine. The particular brand that we have is called Exablate Prime. I think we have some pamphlets, or can get you some pamphlets if you're interested. The big circle there is the MRI machine. And so that's not really part of the specific device that we're using. However, that's just the MRI. And so that's a big round magnet, basically. And that helps us take pictures of the brain and guide our treatment. The device is the one that's sitting on the table there, and it looks basically like a helmet that fits over people's head. Within that helmet are over 1,000 small ultrasound wave creators, and they're tuned specifically to all converge on a single point within the brain. A non-damaging, low-intensity ultrasound wave gets sent through, and where all of these waves converge, the brain heats up and it disconnects the circuit. This is a patient sitting on the table with the helmet positioned around their head. They're wearing what looks like a halo around their head, and that helps them stay perfectly still, and that way, as they take breaths and blink their eyes, it doesn't throw off our millimeter accuracy. On top of their head sits a cool reservoir of water, which allows for passage of the ultrasound waves reliably and safely. This is kind of a visual representation of how the ultrasound waves converge on a single point, in this case in the thalamus. And then another representation there where things are converging on the small part of the thalamus there. And this is the after effects on the MRI. And so one nice thing about studying brain anatomy or looking at pictures of the brain is there's two halves and they're supposed to be the same. And so in this picture, the front of the head is up at the top, the back of the head is at the bottom, and then on either side, the brain is symmetric. And so you can probably make out there's a small teal line, which is our measurement from the midline. It's generally dark in that thalamus area, and you probably can make out on one side, toward the center of the photo, that there is a white spot. And so that's where our opening is. And so that's where we treated somebody, and their tremor went away.
What we did today was we used a new treatment with focused ultrasound to non-invasively treat my patient who had Parkinson's disease. The procedural technique involves placing a frame around the person's head. So imagine a metal ring like a halo, and that attaches to the person's head with some pins after local anesthetic is given. And then that serves as a point of reference and also to hold the head and the brain very perfectly still during the procedure. And the rest of the procedure is conducted in the MRI scanner, and we use a specialized piece of equipment that focuses ultrasonic waves at a particular spot that we choose within the brain. And the anticipation is that we would see at least 60, but up to 90% reduction of the tremor. So we do a lot of testing with the patient. We want to see their tremor, and then we want to make sure we're correctly targeting the area of the brain that's involved. And we can do a couple of test treatments without causing any other permanent side effects. And once we see that we're getting the desired effects with the tremor being reduced, and that we're not seeing any unwanted side effects, then we can go ahead and give what I would call a full dose of energy with the ultrasound waves to that particular area of the brain. Anytime we see such an obvious visible change in the person's neurological function and such a life-changing improvement, I just think that's emotional. So to be able to do something like that that's really safe, and we see, the immediate effects without really any substantial recovery, I think that is kind of amazing.
Let's go back in and do the lot. Let's get it done while we're here. Thank you, sir.
It's easier than anticipated. Actually, I didn't experience anything negative, no severe pain, nothing. I'd say it went 100% like it should have. Advice is to seek out the closest institution that provides this care. And if it's Riverside, you shouldn't have a problem. Dr. Salvin's a good guy. I would recommend anybody to have it done, and I'm going to have the left side done as soon as I can.
Patients now are becoming very savvy. They're self-educating. They like the idea of the immediate effects, maybe being able to avoid having something implanted, and avoiding a trip to the operating room and the expected recovery from an operation.
That is MRI-focused ultrasound. Also, another one of our favorite procedures to perform since it's so successful and the recovery so easy. A few final thoughts. Movement disorders, the tremors like we're talking about today, very common. Medications still remain the first-line treatment for folks, and seeing a neurologist is always the best bet to start with the least invasive things that are plenty helpful for most folks. But over time, if medications become ineffective as people's disease progress, if side effects become intolerable, procedures like deep brain stimulation and the MRI-focused ultrasound thalamotomies are very safe, they're very well tolerated, and can provide really long-lasting improvement in people's symptoms. I think that's all I have, but I'm happy to take any questions about surgery or... So especially the MRI-focused ultrasound, without it being an invasive procedure, really the sky's the limit. So as long as people can lie down flat on the table for about an hour, they can go through the procedure. And in the video, I know a small detail that got kind of clipped over, the actual procedure for the MRI-focused ultrasound that really makes the difference, it takes about 30 seconds. That whole business, all morning, is all about getting ready and getting on the table and sitting still and getting comfortable. It's amazing how quick it works, and it's why it's so great for folks that even have a lot of good years behind them. Sure, and so things have changed, even though the procedure's been around since you would have been one of the first few folks to have it, I suppose. We have learned a lot about it. And so we've learned about how to be more efficient with it, and that we need to reach certain temperatures and certain energy levels, otherwise people can end up just like you, that have the treatment, it's fantastic, but it wears off. And then the same thing actually for the deep brain stimulator. Sometimes, of course, we'd have to meet with you and go over your case, of course, but a lot of times we can look at things and a different set of eyes may see something different with their deep brain stimulator, such that easily, I suppose, it could be programmed differently, or in my training especially, being at the university, we saw a lot of folks for second and third opinions, and we would replace the wires and into a better spot, and they work a lot better. So, but it's certainly worth looking into. I think both of them can work just fine, even if you don't have very severe disease. I guess the more of a problem you have with your disease and the more that it limits your life, the more room there is for improvement. And so our patients with the most serious tremors notice the starkest improvements. And so one thing that I didn't specifically mention for both of these procedures, they involve a haircut. Specifically, we shave people's head for specific regions to get the procedure done in the proper way. And so my threshold usually, especially for nice ladies that I meet, if you feel like your tremor is bad enough for me to shave your head, then I believe that it's bad enough to do surgery. So that's correct. For the ultrasound procedure, it's so the ultrasound waves don't get caught up on air bubbles that collect in your hair. Otherwise, it'll cause heat and it'll feel like your head's catching on fire. So we shave the head and avoid that effect. It also makes sure that the energy, one, because you don't want it to be uncomfortable on the outside of your head, but two, we want to make sure the energy makes it to where it's supposed to be going. Otherwise, you may not get the treatment effect that we think we're giving you. For deep brain stimulation, mainly it's because we're putting a permanent implant in somebody's head, and no matter how much you wash your hair, I can tell you as a brain surgeon, it's still pretty dirty. And so when it comes to putting sterile, permanent things, foreign bodies in people's heads, we have to have everything just absolutely positively clean as possible. And so that's where the head shaving comes in for that. Sure. So with the thalamus, there's many compartmentalized areas. And so for most folks, we have a lot of clues as to where the proper target is. We make special measurements based off of other landmarks in the brain that don't shift from person to person. And so that gives us a good start. We can also make out different structures on the MRI. The reason that we have folks awake during the procedure is to avoid the unwanted side effects. And so with the ultrasound, the actual dose of the ultrasound to deliver that takes about 30 seconds of giving the high intensity ultrasound waves. By delivering very low intensity ultrasound waves, we can give people a idea as to what they're going to expect after the treatment's done. And so with a low temperature change inside the brain, you'll start to feel what will be the permanent effects for you once we give the real dose. And so if we were to start giving somebody the dose and maybe the edge of their mouth feels numb, or maybe their hand feels a little weak, we can say, well, let's stop. We know how the anatomy works in that part of the thalamus, and we can adjust our target a millimeter to the left or a millimeter to the right or a half a millimeter up or down to get away from that area that's causing side effects and focus more of the energy on the area that's controlling the tremor. And so that's one of the nice things about these functional procedures and having people awake. Even though it does make for a weird day to be awake during a surgical procedure, it makes sure that we don't cause permanent effects like that. I don't think so. And so the reason for that is the deep brain stimulator has metal in it. That's how the electricity gets there. And with that metal inside the brain, it distorts the way the MRI looks. And so we can't use the MRI to target areas within the brain since we can't see them. On an MRI, metallic objects show up really basically as a shadow. And so it obscures our view of the target area. And so while people can have the ultrasound treatment and then later get the deep brain stimulator, you can't have a deep brain stimulator in the general region that we would like to consider an ultrasound procedure. However, if people have a deep brain stimulator and it is not working or they don't like it, we can take it out and then consider an MRI-focused ultrasound procedure. Ultimately, it's up to the patient. And so whatever people tell me is what we're happy to do. Usually, people will choose to have their dominant hand treated. Some people pick very much the opposite. If they're very nervous, they say, well, if you screw up, it'll be my non-dominant hand. And I don't try to argue otherwise. I'm not worried about that. But really, it's whatever people tell me, I'm happy to do. But most people choose to have their dominant side treated. And then in the handful of people that haven't come back around to get the second side treated, a lot of times it's because their tremor gets better in their dominant hand. And even though they still have a tremor in the other hand, they can still get through life with one good hand. Oh, no, not at all. And so you have to shave your head twice, I suppose. Yeah, I understand. Yeah. So the first part of the first procedure for whichever hand you choose is done one day. and you get your head shaved that morning for that procedure. And then anytime 9 months or more later, you can come back and have the other side treated. And it's a day that's just like the first day. So you get to shave your head again. You got it, yep. I will say, we've done this procedure for plenty of folks. We have found out recently that we can actually prescribe a cranial prosthesis or a wig, and it's covered by insurance.
Okay, everyone. Well, that does officially conclude today's event. Again, we really appreciate your time and for being with us this evening. If you want to grab a light snack to travel with, help yourself. We also have both our neurology and our neurosurgery practice leadership here. They have bio cards for both Dr. Lamm and Dr. Rajan. If you have questions about how to make an appointment, get a referral, we're happy to answer those questions. Come see Brittany or Heather before you leave. So have a great evening. Safe travels.